only sharing it with one person. So it's not going to be like broadcast or anything like that. Alrighty. So I'm going to pull up my slides real quick and just kind of talk to you about the class very quickly. And I'm going to talk a little bit about your stay here in the hospital. We do have a tour, a virtual tour, the first Saturday of every month at 10 a.m. And you can go there on that website that you registered. If you just Google UVA Labor and Delivery Tours, or I'll put the link in the chat. So it's the first Saturday of every month, or the second Wednesday at 6:30. But I do want to talk a little bit about your stay here at the hospital. So I've already introduced myself, prenatal education coordinator, and what can you expect from this class? So part of the way I've been trained and the way I do this is it's evidence-based information you're going to hear. It's not going to be Diane's opinion about epidurals or what I think you should do about your baby. The information that I get is based on the latest research and the latest findings, and what we suggest while you're here in getting your care here. We are going to talk about your stay in the hospital. I'll be referencing what you can expect, what staffing looks like, who's who in the hospital, because the reality is most of you have never, ever been hospital patients before. And, some of you I know either work or your spouses or partners work in the hospital. How normalize some of the things that go on. And then especially when we talk about postpartum care, at the end of at class 4, we're going to talk about local and UVA resources. Not just your pediatrician, but the many, many parent groups that are out there. There's Facebook groups that are well moderated. There are becoming more meetup groups. There are Stroller Fit, there's Hike It Baby. There's lots of things that, especially as we kind of get back to normal, people are doing safe distancing groups. All right, so we're going to talk about general overview of labor and signs of labor, when to call or come to the hospital. Next week, we're going to talk about comfort measures, relaxation, positions. If you get an epidural, one of the trade-offs in getting an epidural is you're not going to be able to walk around. You're not going to be able to get up and get on a birth ball and move around. However, that does not mean that you're going to be at the mercy of gravity. Your nurse is going to, and your team are going to help you get in different positions using the labor bed and different things like a peanut ball, which we'll go over, to help get you somewhat upright, maximize your use of gravity, and but positions, if you are really helpful, especially as we talk about second stage labor. So we'll also talk about what partners can do. Back in the day, when your parents were taking Lamaze classes, or they used to call the dads coaches, which I think puts way too much pressure. Partners and labor support are there to love moms through this and love each other through this. And there are some definite hands-on tasks that are helpful during labor of bringing, things like counter pressure and that kind of thing that are going to be helpful that you can learn about and your nurse can reinforce. But we'll talk about partners' needs and pain meds. Class 3, we're going to talk about second stage labor, pushing, and the first couple hours after birth. Cesarean birth, we'll spend a good amount of time, because even if you aren't planning on having a cesarean birth, your labor may go that way. And I think it's important as women of childbearing age to know a little bit about cesarean birth. because even if you don't have a cesarean birth, you will probably have a sister, cousin, aunt, neighbor, someone in your life process, and also the recovery from that. I forgot to put on here because I changed my slides. Newborn care. Class 3 will start the newborn care part of this. The reason why you're all doing this, baby, and that spans everything from what to expect in the hospital, what are the common procedures that are done, and then normal newborn, what they look like, how they act, sleeping and not sleeping, and crying, fussiness, diapers, umbilical cord care, bathing, lots of information. It's not going to be the end all be all of your information, but it's a good foundation. And I'm going to give you a slide deck with fantastic links. And then we will talk continuing class 4, postpartum care, recovery, emotional health. Now, I teach a separate class called Bringing Baby Home, the postpartum plan, on the third Wednesday of every month. That's like an hour and a half class. And that is about postpartum. And while the stuff you're going to learn on class 4 is very focused on the physical aspects of postpartum, that class is more like planning for going home and kind of housework, how to get ready, kind of things. A little bit more practical, hands-on information. And if you want the slide deck and the information that goes with it, if you're just kind of classed out, I can totally send that to you. Okay, so the way I teach, I'm fast and furious, but I'm also going to pause every once in a while for questions. And if you want to unmute yourself, also, WebEx is such that I can't see the chat while I'm looking at these slides. I haven't figured it out. No one's helping me. But so if you have a question, you can either unmute yourself or you can put it in the chat. And as I change slide decks, we can come back to it. Don't feel like you're interrupting me. So just a couple of slides about your stay. And I'll talk a little bit about COVID precautions. Main hospital, labor and delivery, and postpartum are both on the 8th floor. They're 2 separate units, but they work together. To get here, just wayfinding, you're entering the main hospital, either through the main entrance or the emergency room after 9 p.m. and coming up to the 8th floor. Now, I'll read clinic visits, they'll remind you of this, but wayfinding is pretty easy. It's very likely on labor and delivery that you may do a little short stop in what's called the triage rooms. They're on the labor and delivery unit. They're all private rooms. They're where, before they admit you with labor, right, they need to do an exam, cervical exam, put you on a monitor. If you're getting induced, you get directly admitted, and for a planned cesarean, you wouldn't go to triage. That phone number I put in the chat, 434-924-2022, rings right into labor and delivery. And that's an important number to have because that is your 2 a.m. phone call number. There's always a nurse to talk to you and available to talk to you about questions you may have. Now you can Google this stuff, but it's really nice to call, have them pull up your chart and talk to you very specifically about your care, whether it's time to come in, if you feel like you're having contraction, really broke or not. If you're worried about fetal movement, that happens a lot as you get to 38, 39 weeks. Baby runs out of room and their movement kind of slows down. And it's normal for moms to get nervous about that. So rather than worry, use that number to labor and delivery as part of your health care. It can also prevent you from having kind of a false alarm, coming to the hospital, thinking you're in labor, and being sent home. So it's important. On labor and delivery and postpartum, all the rooms are private. They all have their own shower and bathrooms. Everything is provided for you. We'll talk later on about what to bring, but really, if you brought nothing to the hospital but your phone, you'd be fine. They have linens for both you and your partner, all of the diapers, wipes, everything, toiletries for you. So if you're going to bring something, someone mentioned snacks. Snacks are really good. So little amenities, right? Your own nice lotion, your own nice brush that you use. But really, if you came with nothing, they'd find a charger for your phone and you'd be fine. Labor and delivery for a couple of hours after you have your baby, just recovering. We'll talk more about that. And then you get moved over. This is where I'm talking to you, is the mom and baby unit, which is 8 Central. So a typical stay is 2 nights for a vaginal delivery, right? And then 3 nights for a cesarean birth. Want to go home, be aware that after you have a baby, you're 2 patients. So in order to get discharged, the pediatric do the exam and do the paperwork and assess baby, get ready for discharge, and the OB team does mom. So while it can happen after 24 hours, have a little grace with the teams as they try and coordinate and get you out the door. So so it's really your choice, and also what's going on with you and your baby. They may suggest that you stay another day if you're having some breastfeeding issues. Yeah. Just COVID wise, we are, of course, screening you and your partner at the door, just check. And then masks, we're asking you to wear the masks when you have providers or staff in the room. Okay. Moms in labor can take their mask off because, as we learn more about labor, this is a somewhat athletic event, and oxygen and sensory stuff happens. So you can take that off if you need to. Trying to think of what else. Oh, we are doing, if you're admitted, like let's say you think you're in labor, you come up to triage and they admit you, or you are admitted for cesarean birth, they will do a COVID test on you. They're doing that for all admitted patients. If you have immunization, if you have had the vaccine, I would bring the little card with you. Let's see. So in the mom and baby unit, we have a nursing team that takes care of you. We have pediatricians who are UVA staff who will be doing all of your care for your baby in the room. We have in-room maternity care. So each morning, the pediatrician knocks on the door with his or her team, and they'll do the newborn. And that happens in the room. And that was pre-COVID. That's just the way most hospitals are running now, that nursery care, having the babies in the nursery separate from their parents, is really being phased out. It is safer for your baby to be in with you. And also, believe it or not, you get more rest with baby in the room with you because you're not getting interrupted all the time with someone bringing your baby in and out. And also, as a new parent, you're going to be like on high, you're going to be high connection to your baby. So in the old days, when we'd take babies away, moms and dads wouldn't get any rest because their baby wouldn't be with them. It's a very innate thing. So baby is in the room with you. Lactation, if you're choosing breastfeeding, lactation consultants are here 7 days a week, and they're also with you, available by phone, and then either telehealth, they can talk to you, or in-person visits. First. They'll bring food on their own. Their period upstairs. Work of birth certificate. Okay, let's see what questions you guys have. Pediatric aspect of this, when we talk about newborn care, you should, especially those of you who are doing, you should think about which pediatric practice you want to use. You don't have to drill to a particular doctor. You've got someone in mind. You can, choose one now and change later, but you will be seeing that pediatrician or that pediatric or family in fact, a day or two after you discharge from the hospital. For a second. Can you enter the number? Oh, I'm not seeing anything in the chat. Of course. All right, 434-924. Labor and delivery. And breastfeeding medicine program. And to breastfeeding class have specific about breastfeeding, that 982-316 breastfeeding. Make an appointment for you, telemedicine, prenatally. I'm going to pull up another set of and twins. Yes, can someone say yes?
Yeah.
Okay. All right. So I move back and forth between this program called Motherboard, and I like it because it's pretty snazzy. So we are going to talk about signs of labor, because that's always something people are worried about, concerned about, because our American folklore from TV and movies about labor is what? Women go into labor extremely quickly, right? That's how it happens in the movies. And their water breaks spontaneously, and you barely make it to the hospital, right? It's always a big rush. When the reality for first-time moms is pretty much counter to that. It doesn't mean that there's urgency when you start to have feelings like contractions that get longer, stronger, and closer together, but that scenario of really intense contractions coming kind of bolt out of the blue does happen, but it's not the typical picture. Same thing with your of membranes, what we call that, where your water breaks and you immediately start having intense contractions. That happens. That's maybe like 10% of labors start that way. The vast majority of labors, as we'll learn a little bit more, have a phase of early labor where contractions kind of slowly build up. So I'm going to talk about contractions and your uterus and your cervix, and just kind of as a baseline for this for the stages of labor. So let me just kind of give the big global picture. A typical first-time mom's labor is about 14 to 16 hours. That's kind of if you're going through an obstetrics textbook, that would be kind of a typical labor. But as you have heard from people, no doubt, in your life, when people tell their birth stories, they are either saying, oh my gosh, my labor was really fast. It was like 7 hours, right? Or they might be saying, I was in labor for 28 hours. Why this discrepancy? There's a number of different reasons behind that, and it's also how long who are saying they are in these really long labors are typically talking about a long period of time in early labor when you're at home or when you're being induced and you're in the hospital, when contractions are mild, manageable, and usually not requiring an epidural. So just want to give you the big picture. Let me take a sip of water. So when we talk about pushing, we're going to talk a lot about your pelvis because the flexibility of the pelvis in different positions is really key to pushing baby out, having your baby rotate and get in good position. What's important in the first stage of labor is your uterus. So before you got pregnant, your uterus was about the size of a pear, right? And now it has grown significantly, right? It's hosting your baby, your amniotic sac, your amniotic fluid, placenta. It's grown tremendously. And your uterus has really strong muscle fibers in it, stronger than ones in your heart or your arms or your legs. And those muscle fibers are there to make contractions. Contractions, just like if you were to make, like a Popeye muscle, right? And you keep on doing that, and you keep on doing that. What do you mean? Same thing with the muscular contractions of the uterus, right? Why does the uterus have to contract? It's a mechanical process to open up, dilate, and efface your cervix. Cervix is at the top of the vagina. It's the opening up into your uterus. Before you go into labor, that cervix is going to be firm. It's going to have a little hole in it called the os, or the eye of the cervix. It'll be closed and firm. What has to happen through this mechanical process of these contractions happening is that cervix needs to soften, and it does so with hormones. But with each contraction that lasts about a minute, it pulls up on the cervix and dilates it, opens it up, and effaces it, thins it out. That's a kind of a tandem process. So let me look at dilation. See, here's another way of looking at this. Dilation from completely closed to 2 to 3 to 4 to 5 to 6 to 7 to 8 to 9 to 10. The cervix opens completely. You probably heard that term. And what it causes that is each 1 minute or so contraction pulls on those muscle fibers and pulls and opens up that cervix. So you go from 0 to 10 centimeters dilated. There's a couple of things I want to note here, and I'll see if you guys have questions. Notice that at all of these pictures, baby's head is down, and that's how most babies, the vast majority of babies, will dock around 36 weeks. Some babies are breech, meaning their little rump is down over the cervix. I'm not going to get too much into that, but around 34, 35 weeks, your doc or your midwife is going to assess where your baby's lying. If their rump is down, if they're breech, they're going to give you some options. One is to try and turn that baby manually. It's called an external version. They can also give you some suggestions to try and get baby to flip. But baby really needs to be head down in order to do a vaginal delivery. So if your baby remains breech, they're going to schedule a cesarean. Head of a baby is the biggest part of them, is the largest part, and getting through the pelvis, whether baby's big or small, is the part that requires more flexibility and to get through. Okay, dilation effacement. So it may be that your doctor may say, let's say you're 38 weeks. She might say, she might offer to do a vaginal exam and see what your cervix is doing. If it's soft, if it's dilated a little bit, if it's effaced a little bit. Now, let me rewind a little bit. Some of you may be having Braxton Hicks contractions, named after the two doctors who discovered them. I always think it's funny, these things are named after doctors who discover them. But Braxton Hicks contractions are, I used to call them false contractions, but it's okay. What they are is feeling like your uterine muscles are kind of tensing up a little bit. It's okay to have these, and it's okay not to have these. Some women have a lot of them, especially after you go up a flight of stairs or you eat. It's not as intense as a labor contraction, but it's a similar principle of those uterine muscles tightening and flexing. Okay. So week 38. So let's say you have a vaginal exam at week 38. Your doctor might tell you, okay, your cervix is soft. There's been some changes in your cervix. You're maybe 1 centimeter dilated, a little bit effaced. It means you've had some cervical changes with these Braxton Hicks contractions or even without them. Right? And so it means that it doesn't mean that you're going to go into labor that night. It just means that there's been some cervical changes. So that can be a little frustrating because you feel like I've changed. My cervix is a little bit dilated, but it could be, a week or two. Right? So we like to say cervix is not a crystal ball, but they can offer you that exam and tell you if there's any changes. During labor, your nurse or your physician will do a cervical exam to assess whether you're in labor or not. We'll talk about when to come to hospital, but usually people are advised to come to the hospital when their contractions are 5 minutes apart, and that roughly coincides in active labor. They will check your cervix maybe during the course of your labor, but they really try and minimize the amount of vaginal exams they do for a couple of reasons. Even with excellent hand hygiene and wearing gloves, each time you do that, it's a potential risk. It elevates a risk for infection, even with excellent hygiene. 2, it really hurts. It's uncomfortable, especially when you're in labor. 3, they can usually tell on the monitor or the Doppler and also how you're responding to contractions, where you are in labor. So it's not like they're coming in every hour on the hour checking your cervix. They're going to do it for specific diagnostic things. Before we talk about signs and symptoms of labor, I want to just kind of talk about the nature of labor contractions and how they're different from these Braxton Hicks contractions. There's definitely a wave or an arc-like sensation to real labor contractions. What most women will tell you, and you experience, tighten up, those muscle fibers tighten up and gradually, well, they're about a minute long, so there's not really much gradual about this, but will get more and more intense and reach a peak of intensity. A peak of intensity, or the hardest part is, the most painful, and then let go. Okay. And then there's this interval Mother Nature gave us in between contractions before you get ready for the next one. And in active labor, when you come to the hospital, this is what we're looking at, 5 minutes apart. Now, when we talk about early labor here in a second, like what is usually how you start off labor, we're talking about contractions that may be 15 minutes apart, 10 minutes apart, but getting longer and stronger and closer together. So let's say you call that 924-2022 number at 4 in the morning and you've been having contractions. That triage nurse is going to ask you some questions, which you'll be able to answer because you're experiencing this. She's going to ask you the frequency. And the way you measure contractions is you start at the beginning of one, count that contraction, and then the minutes apart. So 5 interval of about 4 minutes. There's apps for this. And I kind of joke, but it's true, that a sure sign of it's time to come to the hospital is when mom gets frustrated with partner timing her contractions. When it gets old, or when she's like, no, stop it. Irritability. So frequency, how long are they? How far apart are they? Duration, the start of one to its end. Is it a minute long? Is it 30 seconds long? This isn't necessarily cookie cutter, but typically a contraction is about a minute long. But it will tell them something if you're having, 90-second contractions. And the most important thing is intensity. How do they feel? Another line that is constantly used is come to the hospital when you can't walk or talk through a contraction, or text now. When a contraction is enough that you have to kind of stop talking and really concentrate and breathe through it, that is active labor, time to come to the hospital. So intensity is the greatest predictor of stage. Again, one other thing I want to talk. I mentioned baby's head was down, and where I was going with that. When baby's head is down where it should be, the mechanical process of those contractions, pulling on that cervix, opening it up, dilating it, effaced it, is really optimized by baby's head, the weight of baby's head, that gravity. It makes sense. That more pressure on the top of that cervix will help that dilation. It'll make it more effective. So that's where these positions come from. You can certainly lie down if you're feeling tired and get into different positions. It's not going to slow everything down, but the more you can think about getting either semi upright right? Or even on your side with, your with the what's called a peanut ball. Most of you are probably sleeping with a pillow in between your legs, right? Because it feels good to have your pelvis open, quadruply so in labor. Okay, I'm going to pause and see if anybody has any questions. For after, too. Signs of labor. So this is in your book, and they're going to talk to you about this, but it's just kind of good to have a kind of big view of this. So the bottom line, there's soft signs, little features about your body, and that are telling you that there's changes happening chemically and physically, that our labor is on its way. To hard signs, which are evident, obvious, and empirical. And the biggest one, the most important one, is strong, regular contractions. Contractions that get longer, stronger, and closer together. It's not unlikely, or let me put it this way, it's normal for especially first-time moms to have a couple, maybe one or two episodes of what we call false labor, where you have some contractions that are kind of mild and they have that wave-like pattern, and you're going to get all excited. Call clinic 9 to 5, call them, or call up to the labor and delivery, and they're going to have you kind of watch and wait unless they're super intense and really close together, because sometimes these early labor contractions, this kind of away. The most common thing your nurses will tell you is, like, you call and say, I'm having contractions every 15 minutes. They're going to tell you to drink some water, right? Because if it's false labor, it's just going to kind of peter out. And every pregnant woman probably needs to drink more water. Do something differently than what you're doing now. So, like, if you are laying on the couch and Netflixing and you're feeling these contractions, get up and just do a little walk around the house, maybe a little stretching, maybe eat something, take a shower, right? Or if you're active, if you've been outside or you're at work, sit down and rest. And if it's real labor, it's going to keep on marching when you change your whatever you're doing. If it's false labor, it's going to peter out. It'll peter out more quickly when you change your behave, what you're doing. Okay. So I didn't make these slides. They're pretty, but I would have worded some of these things a little differently. So what they mean by baby drops, it means baby engages or lightens into the pelvis, usually around 36, 37 weeks. Those of you who are due in May, has happened, that baby body, their head moves down into the pelvis. They kind of dock in the pelvis. And we call this engagement, lightening, or your baby drops. People who know babies will look at you and say, oh, your baby dropped. What you'll feel, moms, is you will feel a definite sensation that you have more lung volume, like you can exhale a little bit. You'll also you'll still feel those little critter feet right in your ribs, but it's not going to be quite as intense pressure right here. And what you're going to feel, there's always a trade-off. What you will feel is more pressure on your pelvic floor, in between your legs, on your bladder. Yeah, more. You heard me. More pressure on your bladder. And definitely feeling a sensation that you can feel the weight of baby's head. So you know that kind of like cartoonish wobbly walk in late pregnancy? Not that you're going to be doing that, but you'll definitely feel a body change. So it doesn't mean that that it's not really necessarily a hallmark of the start of labor. It isn't actually, but it means that your body is getting ready. So a lot of, if you go out and you read on the internet, a lot of energy around the mucus plug and all that. So what happens, I mentioned it a little bit, that yes, the contractions of the uterus mechanically open up and dilate and efface the cervix. But what has to happen before that is your cervix has to get soft. It's, right now, um, your cervix is hard tissue like your forehead. In order to be able to be pliable and able to dilate, it needs to be softened. And what does that? Prostaglandins, these hormones called prostaglandins. They soften the cervix and your pelvic floor and get your body ready to change. So what happens with that? Your cervix will soften, and it will open up a little bit. And what you might see after you pee or wipe yourself is what's called the mucus plug. It just gets better and better. So mucus plug is your body's kind of second layer of protection for your baby. You have the amniotic sac, it's like a protective seal. And then you have that mucus plug, and it's like a and your body keeps on making cervix mucus, but when your cervix starts to soften, it opens up, and what you might see is you wipe yourself after you pee, you might see it on toilet paper. It just looks like a little piece of mucus. It might just fall in the toilet. You never see it. Your body will still continue to make mucus. So what you might see, especially if your mucus plug comes and it's been a couple of days and you haven't gone into labor, you might see a vaginal discharge that is more heavy mucus. You don't need to bring it in or take a picture of it unless you want to. Our triage nurses are like, please tell them they don't need to bring it in. We'll take their word for it. Um, so so mucus plug, that's something you see, and yeah. Another thing related to this hormonal change is, I'm going to get back to nesting here in a minute, but restlessness and irritability. Sometimes, especially if you're a hormonal kind of gal, if you're a PMSy kind of gal, sometimes our hormones can make us feel a little bit more restless or irritable. Actually, I'm going to talk about nesting. That may, because of prostaglandin and also a little bit of mother's intuition, which you have now, right? You've gotten that gift. Nesting refers to a kind of a response of wanting to get your nest ready before baby comes. So it can look, if you talk to people who've had a baby, regardless of when they had that baby, you'll probably get some good stories out of people, because it can look a little irrational and a little unbalanced, right? It can look a little intense. So women will often report that they were just like vacuuming their house and doing all this laundry and cooking. My neighbor repainted her nursery at 39 weeks and didn't get all the way through repainting it. That was what she did. And it was halfway painted and they left it that way for two years. So if you feel this restlessness and irritability and this feeling like you want to get your nest ready, please try and ignore that. And partners, this is where you come in and try and talk her down from this, because it can, not everybody has this, but if you do and you tend to be kind of a, a busy kind of person, this can potentially, these weeks as you go into your due date, as time to rest, to recalibrate yourself, and especially as due date comes in, um, to rest almost like you're going to be doing a big 5K or more. Nesting, restless irritability, nausea, and diarrhea is related to the prostaglandin. Not everybody has this. So it can look like you feel a little punky, a little sick, almost like you have food poisoning, right? And then diarrhea, I'm going to turn the lights on. Diarrhea can happen, call it nature's enema. um, but it almost feels like you've eaten something wrong. So just know that if you're feeling a little out of sorts, if you're feeling a little irritable, and let me reassure you, some people have none of this, but others, these are soft signs to look for. Your cervix starts to soften and open. And then another little soft sign is cramping and lower back pain. All pregnant women have back pain. This just comes with the territory of your body. But this feels like a throbbing kind of menstrual back. And what's happening is the hormones, and also as baby descends even just a little bit and puts more pressure on your tailbone, on your pelvis, right? There, it can cause that discomfort. So hard signs, contractions, they get longer, stronger, closer together. Your water breaking, that's an empirical sign that labor is on its way. So your water, you're going to hear about this in your clinic visits. So I'll be somewhat brief, but just to give you the big picture. Sometimes your water breaks and nothing happens. It can be hours until you have contractions, right? Sometimes you go into labor and have extremely productive contractions and come to the hospital and labor for a number of hours, and your bag of water is still intact. So it can go all different ways, right? It eventually will break. So I'm kind of walk down the pathway of options with you. So let's talk about spontaneous rupture of membranes. That means it breaks on its own. It can happen. Let's see. The best way in two different kinds of ways. It can either be a really big spurt of water where it is a gush, where there is no question that your water broke, because it's usually like a liter of amniotic fluid, right? Your cervix has got to be open for this somewhat. And so most water, if your water breaks spontaneously, is going to be that gush. Sometimes it comes out as a little trickle, okay, where the rupture of the membrane is smaller. And so you can feel almost like you're peeing yourself, right? Which is not out of the question in the later part of pregnancy, right? Lots of women have a little bit of urinary incontinence. So if you're feeling like that you're experiencing more wetness, or after you pee and you feel your bladder empty and you wipe yourself, you feel more moisture or wetness, or you notice that in your underwear, definitely call your provider. in both sense, whether your water breaks in that gush or whether time is really of the essence. Your team is going to want you to go into labor between 12 or 16 hours after your water's broken. Usually you will, right? But that protective seal is off and your risk of infection over those hours, I mean, after those, 12 to 16 hours climbs. So the bottom line is you want to call your, during clinic hours, you would call your clinic and let them know your water broke. After 5 o'clock, you would call labor and delivery and they can advise you. Now, if it's a trickle, they will definitely want to test that because it might be a little urine. And there's a way to test that, whether it's urine or amniotic fluid. So there's an acronym, like let's say you call up here and in labor and delivery and say that your water broke. The nurse is going to prompt you. She's going to use the acronym, she'll use other ways, but the acronym COAT is typical. She's going to ask you, was there a color to the amniotic fluid? It should be clear. She'll prompt you, was there any black or brown or green streaking? Sorry. And what she's asking and prompting you for is looking baby's first bowel movement. All babies have this meconium. It's this dark, tarry, sticky stuff in their bellies. And usually you don't see it until the first day of life, their first poop. But sometimes they poop in utero, right? They just let it go. And sometimes due to stress, sometimes just because. So that's why they're assessing that. So it doesn't make your labor situation that much different. Where the worry and the issue is when your baby is born, making sure, ensuring, and monitoring that baby doesn't inhale that meconium and get it into their lungs. So during the course of labor, they'll probably put you on a monitor, watch you a little bit more closely if it's a meconium stained fluid. But that real assessment and that concern is right after baby's born. Okay. So color, odor should have a very slight ammonia smell, right? If there's a bad smell to it, it could be an infection. Not typical, but she's going to ask you, was there color, odor, amount? Did it come out in a gush or did it come out in a trickle? And then the time. Doesn't have to be Swiss time. They'll guide you through that. So that's spontaneous. Sometimes your water during the course of labor, that bag of water is still intact, and your provider, your midwife, or your doctor will talk to you as you progress through labor, whether it's induction or spontaneous labor, on breaking your water for you, what we call artificial rupture of membranes. And the reason, I mean, that's something they have to get your consent for. It's a very low tech thing. They basically break that bag of water with what appears to be like a little crochet hook. It's called an amnio hook. The rationale for doing that is it can help speed things along, right? Help your contractions be more productive. But that's something that they'll talk to you about and assess with you. So it's not a decision you have to make now. It's just something in the thing. We talked about regular contractions. Again, if I was making this slide, I would not use that word bloody show. We have terrible terms in obstetrics. What that refers to is vaginal discharge that it's very mucousy, right? It could be mucus plug and also may be a little bit blood tinged. That's from capillaries on your cervix as your cervix starts to stretch. So a mucousy bloody discharge. different than, say, period blood. Like if you ever see what we call frank blood or period blood during pregnancy, like where it's all blood, you want to call your provider immediately, or call labor and delivery immediately. This is more of during the early labor, and through the course of labor, you're going to have this discharge happening. And once your water breaks, your body keeps on making amniotic fluid, so you're going to have that kind of trickling through the labor process. And strong downward pressure kind of in your behind. I think that surprises people. They feel a little bit more pressure in their rectum. But really, like I said, strong, long, strong contractions. We talked about contractions in waves, and we talked about dilation. All right. This is perfect. I have about 10 minutes left of this, and we'll see what questions you have. So stages of labor. You have early labor, active labor, transition, which is all part of the first stage of labor, of going from. The second stage of labor is pushing. And that is, we'll talk in much more detail, we'll unpeel all of that. That is anywhere from a short end to from half an hour, which would be pretty short, to as long as 3 hours. Your results may vary, with the same thing of contractions that are about 3 or 4 minutes apart, but the contractions, instead of opening up your cervix, are helping you push your baby out into the world. And then stage 3 of labor is delivery of your placenta, which we'll talk more about it, but real briefly, it's the end of your pregnancy. About 10 or 15, 20 minutes after you deliver your baby, your uterus makes a few more contractions and your placenta sloughs off of the side of your uterus. You push it out vaginally, and voila, you're not pregnant anymore. We'll talk in more detail about that. Okay, I just have to check something real quick. I apologize. All right, so let's talk about early labor. I've already made some allusions to this. This is for the labor, you're going to be at home. If you're getting induced in the hospital, the same thing applies. A lot of these stages apply. This early labor and coping mechanisms still apply. So this is also when, we talked about that variation of some people have, lots of early labor, so they have the long protracted labor. Others have just a few hours of these early labor contractions. And there are some people who kind of just skip through this and have that, sudden onset of labor. But that's the minority of people. So we're talking about contractions in early labor that are usually 10, 15 minutes apart. They're mild enough that you can walk, talk, work, drive, make cookies, listen to music, walk, you can do activities of daily living with these contractions. You don't need pain medication. You may have a couple of them. As they get more intense, you might be like, ooh, that was a big one. But these contractions are just kind of revving up and doing that first bit of dilation. Now, if your doctor or midwife wants you to come to the hospital sooner than 5 minutes apart, Ask them about that, what their recommendation is for you, because that may be different in your case. And if you live far away, that's something to consider as well. So coping with this early labor, sleep. I think that's gonna be hard for first time moms to sleep because you're gonna be excited. But if it's, you should be doing what you would normally be doing in the pace and the tempo of your day. So if you wake up at 1 in the morning with these contractions and they're like every 15 or 20 minutes, try at least to rest your body. Ignore if possible. If you, lots of people can, you can compartmentalize that. If it's at 1 to 8 in the morning, try at least be restful, do something that's gonna distract you. Try and people can sleep through these or snooze through them if you can. But and if they start during the day while you're at work or something, just keep on doing what you're doing for distraction, and just pay watchful, just be watching and waiting. Stay home as long as you can if all is well. We kind of you depending. Move your body, positions, and walking. So it's this line between chilling out, resting your body, eating, staying well hydrated, like you're getting ready for a race, and then periodically getting up, doing some stretches, walking around the block for distraction, but also for some exercise. So you're just kind of in this holding pattern because you don't know if these contractions are going to pick up really fast and you're going to be going to the hospital in 2 or 3 hours, or if you've got a long time, hours and hours and hours. So it's just watchful waiting. Partner labor tips. I like this picture because he's kind of joking with her. Practice timing contractions, but don't fixate on them. I mean, you're going to love her through this. Like I said earlier, if you're getting annoying on doing the timing and everything, she'll let you know, and that might be time to consider coming to the hospital. Be a calming presence. It might be that you joke through this. Offer reassurance and support. Distractions. If she's been laying on her side on the couch for a couple of hours, hey, let's go for a walk, or let's even go for a drive. On the other slide, it says eat and hydrate. That's a really good job for partners to do, is to make little small high protein good meals, little treat meals. And also the logistics of making sure that both of you have your bags packed and ready to deploy. Because while usually it's kind of a gradual process of this labor, these contractions building up, sometimes it does ramp up. So anything partner can do to kind of get the bags packed, get them in the car. Pets are taken care of, your fur babies, you got a plan. So when she's ready to go, you're ready to go. So here's these diagrams again. Active labor, when you ramp up, time to come to the hospital, going from 6 to 8 centimeters dilated, the contractions build up. They get considerably stronger. And like I said, that can be kind of a gradual, longer, stronger, closer together, or it can be, ooh, oh my gosh, that was a big one, right? You'll still have plenty of time to get to the hospital. So they get long, 60 seconds, much more intensity, where you can't walk or talk through them. And this is true of induction, more intense, closer together. Some moms, when they get into this phase, they feel mentally foggy or fluid or dreamy, or what I like to say, and many people in this field, you enter labor land. What's happening is, as things are getting more intense, as you experience pain, you get a little boost of adrenaline. You also get endorphins, those natural feel good hormones that protect us. Um, so it's not unusual for mom to be kind of in a dreamy, kind of unreal state. I mean, you're still going to be able to converse and be lucid and remember everything. That's not what I'm talking about, but just kind of feeling just a little out of it. And the contractions demand your attention. And so we'll definitely talk next week when we talk about comfort measures, about the things that are going to help you relax in between those contractions. Because the trick of it is, above and beyond pain medication and nitrous oxide and all that, what is going to help you is, as you feel the pain of those contractions and you have those few minutes in between, what's going to help you just kind of unclench your body and relax and restore yourself for the next one. So it's not a straight line, detours, accelerations. For example, sometimes people have a really good labor pattern. They come up here, they get they get into triage, and then sometimes coming into the hospital can make them have a little what we call white coat syndrome. They can start to feel a little more nervous as they're in a clinical setting. You know how people sometimes their blood pressure goes up at the doctor? Sometimes that happens. So it's good to kind of know that about yourself. It can happen a different way too, that women get admitted to the hospital and they can kind of like, oh, I'm here. It can happen a different way, that they feel relieved that, they're safe in the hospital, their team is here. So, yeah. So we're going to talk next week all about coping. So I'm going to kind of skip over the next couple of slides of comfort measures. But you see, there's a reason that these birth balls are in every maternity unit in the United States, is because they're awesome. Women like to get into different positions to help take the pressure off their pelvis or open up their legs. So we have those in every room in different sizes. And again, we'll talk more about partner tips, keeping comfortable, making suggestions. Your nurse will help you. Why don't we try this? Why don't we try that? And we'll go through that. There's a couple of things I do want to mention on this slide that are really important. One, I don't agree with. Give undivided attention. Of course, you're going to give her incredible attention through this. But sometimes labor support needs a little break, particularly if things are really slowing down and taking a while. So your nurse is going to be a really good resource to you. They're very good at picking up when you need to go get a cup of coffee or just walk outside, because if you go downstairs, get a cup of coffee, come back 10, 15 minutes, you're going to be a much better labor support person if you've had just a little break. So certainly don't leave when she's pushing or in transition, but and that's something you guys should talk about as a couple, if you're in a couple, about what that expectation is. And sometimes labor just happens and life happens and you've got to wrap up stuff at work, or there's some loose ends you got to do that you might need to step out and do. And then the other big thing is rest when they rest. Really important, because let's say you arrive, hours have gone by, you're not really making progress. Mom decides to get an epidural. She's in the bed, resting. The lights are low, got a little music playing. Labor partner should be on that couch, lying down, snoozing. You should be doing exactly what she's doing. So if she's laying down, resting, you need to be resting. You don't have to stand vigil over her. Okay. If she's laboring, oh my God, you need to be active and with her. Oh, and remember to eat for sure. That's why the snacks. We have snacks, but you want to bring your own. And there's a cafeteria downstairs. All right, 2 more slides, and then I'll see what questions you have. Right before you get fully dilated, ready to push, there's this period called transition. It's the shortest, most intense period of this dilation phase. And what happens is things ramp up. Anywhere from maybe half an hour to as long as an hour and a half, maybe 2 hours. It really depends. But what's happening is those contractions increase in intensity, yeah, and get, you know, closer together. So they're about a minute and a half, and they come every 2 minutes. This period of time. This is opening up your cervix 8 centimeters to what we call complete, or 10 centimeters. Yeah, this is not also a coffee time for you either. So it's hard to convey this, but normal to need a significant amount of support may feel done. It's almost predictable. It is predictable that moms in this stage will say, oh my God, I can't do this anymore, or I am done. I mean, you're just, this intensity is hard. And I'm not going to tell you the magical things that your nurse and your team will tell you, but they're going to be able to tell you things that are going to get you over this hump. There's a lot of motivation here and perspective giving, and you're almost going to meet your baby and you're doing great. So there's a lot of emotional support that comes here. If you have an epidural, right? One of the thing that the epidural does primarily is make you numb in your behind, your upper legs, in your waist, and in between your legs. And so the pain of contractions, if your epidural is working correctly, you're not going to feel that pain, but you're still going to feel some pressure. You can't block it all out. With transition, while you may not feel the intensity of these contractions one after the other, you still may experience what all women will have is nausea or shaking. This is really intense. So what often happens in transition, moms their legs start shaking, kind of, you don't have control over it. It's involuntary shaking. You may feel chills. You may get nausea. You may, if you're someone who's prone to throwing up when you're nervous or overworked, or overexcited, or you're exercising really hard, if you get queasy, you might throw up once or twice. And it's normal, it's expected. Rely heavily on support people. This is where, in the movies, when they have moms who yell at their partners, kind of happens during transition. So you just got to take it one contraction at a time. So the other slides are about second stage labor, meaning pushing. And we are going to cover that in much more detail, class 3. So I'm not going to go through those. But like I said, has a variation anywhere from, on the short end, like half an hour, to as long as 3 hours. Contractions every 5 minutes or so. Am I breaking up a lot? I'm sorry about that. About what week do you typically see the soft signs of labor, and how many weeks does it last? That's a good question. So usually you see that in the last week before you're around your due date. Everybody's a little different. So some of you might have, you see that the mucus plug at week 37. You should call your doctor and just let them know about that. Just kind of check in. And then you might not have any other of those symptoms, any other signs until, for another couple of weeks. So everybody's a little different. I'm gonna wait and see if you guys have any questions. When should you decide about an epidural? Really, it's good to walk in with a preference of what you want, but you don't have to decide until you are in labor. And you can say no to it at first. I mean, each and every one of you is going to get a visit from one of our anesthesiologists when you get admitted. And don't look at that as a pressure to get an epidural, but they're going to ask you what your preferences are. And if you want to shoo them away and say, no, not right now, but maybe later, when is it too late? That's a perfect question. In order to get an epidural, they're having to make a puncture in between your vertebrae. So it's a pretty in, specialized, and you need to stay very, very still for that. So that's the main criteria for your safety. So our anesthesiologist will give you an epidural up until you're ready to push. But if you wait until that transition period that I just described, we just talked about shaking and and feeling out of sorts and all that. It can make what should be an epidural is really quick to place. It can make that, because the contractions are closer together, take a little bit longer. And they also have to make sure that you can stay absolutely still. So, your safety is the most important thing. So, I mean, they can still out with your nurse if you're thinking like, I don't know if I should have it. She'll check in with you. And again, no pressure, but she might say, if you're thinking about an epidural, you might want to consider it now. Just getting an epidural slow labor? It can if you get it too early. And so that's why with inductions or going into spontaneous labor and coming up here, they're going to wait until you're in active labor when your contraction pattern is good and strong every 5 minutes or so, and your cervix is definitely changed and open. So it can work both ways. Sometimes when moms get an epidural, they get in the bed and they don't move around, right? And they're not using gravity and they're not using the peanut balls. And that in its own has a potential, doesn't always, but has a potential to slow labor down. On the other hand, there's always a gray area in this. If you get a mom who is anxious and emotional and scared and is tense, and each contraction is just making her just really frightened, um, giving her pain relief and turning the lights down low can make her labor progress quicker, because you have taken away that stressor, right? So it can have two different effects. But just getting an epidural and it's not necessarily going to make things last hours and hours and hours longer. Will they numb the space on my back before the epidural? Yeah. Oh, yeah. 100%. For sure. When we talk about the epidural, they will clean the area off with betadine. They will give you a little local lidocaine, which will feel like a little pinprick, and they're going to make sure you're completely numb before they make that puncture. And by the way, I'm kind of featuring this. When they put the needle in between your vertebrae, not into your spine, they thread a little catheter in there, a little tube, and then they take the needle out. So there's a common misconception that you're going to have a needle in your back the whole time with an epidural, but actually the needle is just there to make that puncture. And that tube is what is taped to your back and then on a pump that will continuously give you that medication. So it never really runs out until they turn it off. Okay. If family history, if I have family of, but I'm a first-time mom, what should I consider reasonable for early labor and when to drive to the hospital with an hour drive? All right, so precipitous labor is, I mean, the way we define it up here is like 3 hours or less. And that's pretty dang fast. I'm going to bounce that question of if you have that family history, when should you consider coming for early labor? I'm going to bounce that back to your provider, your nurse or midwife or your physician. My understanding is that labor patterns, whether you have fast labors or slow labors, is not really hereditary. You know, so I don't think, I mean, I think you should have a plan for it for sure and not be um not sleep on that, but I would definitely talk to your doctor about, instead of every 5 minutes, do you want me to come at 6 minutes, 7 minutes, that kind of thing. Does the epidural affect the baby? Yeah, so the medication they use in the epidural is kind of a cousin of Novocaine. Bifurcaine is called, and it is a numbing medication and it's pretty localized. So yeah, it does go through the placenta to baby, but it doesn't have any kind of effect on babies in terms of medicating the baby. Now, if they use a little narcotic in the epidural, that would go through the placenta and get to your baby. However, that is used really cautiously depending on how far along you are in labor. Right? I mean, they do use narcotic pain medication that goes through the placenta to the baby in labor and delivery, but they don't give it to you too close to delivery because they want baby to be able to metabolize and use up and burn off all of that medication before they're born. So that when they're born, they're born awake, alert, crying, strong. So that whole idea of babies being born heavily medicated and needing to be resuscitated or spanked on the bottom like in the old movies and cartoons, that is definitely a thing of the past. So the epidural doesn't, with the Bifurcaine, doesn't have any effect on babies in terms of their respiration or that kind of thing. Will we talk about nitrous oxide in the next class? Yeah, totally. I mean, just briefly, they're back to using nitrous oxide, laughing gas. That was on a big hiatus because of COVID. And so now they're test, and they can give you a rapid COVID test when you get up here. The worry was because nitrous oxide is, you breathe it in, that it could be aerosolized, and if you had COVID, it could spread more readily. But now it's back in business, and it's a really good option. Okay. Anything else? All right. My experience is that people can only do so much online learning before they glaze over. So I think I'm going to sign off tonight. If you want that booklet that I mentioned, the Enjoy booklet, just send me an email and I will put it in the mail to you. And if there's anything tonight that you have further questions on or you want more information, just shoot me an email. I mean, you all have it, but I'll put it in there. And then what we'll do right off the bat, I think what I'll do, because you guys have so many questions about pain medication, we'll do pain medication right away. Oh, EDU. And on the first class, the first part of class, and then we'll go and do a deep dive into comfort measures. Okay. Oh, is there any reason not to get an epidural? I mean, there's sometimes if a mom has had scoliosis, like a spine issue, or has had spinal surgery, they would want to do what's called an anesthesiology consult on the mom before she has her baby. But there's no reason that would be like a medical reason. But maybe we can talk next time when we talk about pain medication about the reasons. I mean, people have different reasons not to get an epidural. So a personal reason is that some people, because you can't walk around, you can't get up and move around with an epidural, there are some women who that is a big issue too, right? They, the whole idea of not being able to walk and ambulate on their own is is a big consideration for some women, and others don't, and that doesn't matter. There's personal reasons and the way we're brought up and our cultural reasons, the what we've heard about birth, um, other people's experience with it. Some people see it as, and others are like, dial up the interventions, pain medication, whatever. So it's a really private, very personal choice. Is it painful if they have to manually rupture your membranes? No, not at all. Like that spontaneous rupture of membranes, you won't feel it. It's just like a little pop. What you will feel is if you're in active labor, is those contractions will probably get more intense. But it doesn't hurt. Good questions, guys. Okay, fellas, ladies and gents, I am going to sign off. You all have a great week. Enjoy the weather, get out in the sunshine. And again, in the meantime, just let me know if you need anything. Okay, it was good to meet all of you.